Today, I want to explain a tension that sits underneath almost everything in American healthcare. Most patients feel it, but few patients clearly see it. It is the relationship between two groups: the payers, which are the insurance companies and government programs that pay for the care, and the providers, which are the hospitals, physicians, and health systems that deliver it. On the surface, they work together every day and on the behalf of the same patients. But underneath, your incentives have historically pulled them in opposite direction. And a surprising amount of what frustrates people about healthcare is the denials, the prior authorization, and the unexpected bills flows from that tension. Welcome to HealtheNomics podcast. Here we explore the forces shaping healthcare today and tomorrow. I'm Dr. Ayoub Ashraf, a healthcare strategist and consultant. So, in this episode, I want to do three things. First, explain what each side is actually trying to do. Second, show where their goals collide and how the patients end up in the middle. And third, look at how the relationship is starting to change. So, what are these two different jobs? To understand the tension, you have to understand that payers and providers are doing two fundamentally different jobs. A payer collects money in advance through premiums or through public funding and uses it to cover the cost of care for a large group of people. Their core challenges is managing risk and cost across the whole population. So a payer is asking always, is this care necessary? Is it appropriate? And is it the most efficient option? And that is not wrong. That is their actual function which they are supposed to do. Someone has to steward a finite pool of money on behalf of many people. If a payer approved everything without question, premiums would rise until people could no longer afford coverage at all. So the payer, in fact, is the person saying no on behalf of everything who is paying in. It is an important role. It is also a role that guarantees you will be presented. A provider does something different. A provider delivers care to the individual in front of them, and historically under fee for service arrangement. Provider is paid for each service which is delivered. So the provider's traditional incentive is to do act, to treat, to intervene, and to function for the betterment of the patient. And there is something deeper than money here, which I think gets missed. A physician's entire training points towards action. When you are sitting with a patient who is frightened, your instinct is not to consider the finite pool of money across a population. Your instinct is to help this person. That instinct is correct. It is what makes medicine worth practicing. But now put those two side by side. One side is paid to deliver more and is trained to act on behalf of one person. The other is responsible for controlling how much is spent on behalf of everyone. You can already see the collision coming. And notice neither of them is wrong. They are simply accountable to different things. Now we talk about where they collide. The collision shows up in a very specific, very familiar ways. The first is prior authorization. This is the payer asking the provider to justify a treatment before agreeing to pay for that. From the payer side, it is a tool to prevent unnecessary or inappropriate care. While from the provider's side, it is a friction. It is a delay, more paperwork, and sometimes a barrier between the patient and the treatment. Both perspectives are real. That is what makes it so difficult to deal and understand. The second is denials and appeals. When a payer declines to cover something, the provider often disputes it. And the patient, who is the one person who did not design the system, is frequently caught between them, unsure who to believe or who to pay. And the third is contracting. Behind the scenes, payers and providers negotiate to price of care. Large systems push for higher rates, larger payers push back. And they leverage with their authority to decide the outcome. Those negotiations, which are invisible to the patient, they quietly shape both the cost of care and the network available to them. And now, here is what I find most striking about all of this. And it is where the numbers become uncomfortable. All of this friction is not free. Somebody is paying for it. A study published in the Annals of Internal Medicine compared the United States spends on healthcare administration with the Canada spends in this area. It shows that American insurers and providers spend about $812 billion on the administration. That worked out to roughly $2,500 per person. While at the same time in Canada, the figure was about $550 per person, which was about 17% of the healthcare expenditure per person. The researchers estimated that if the United States administered healthcare at Canadian cost levels, it could have saved more than $600 billion in this area in one single year. Now, I want to be careful with the numbers because the estimate depends heavily on what you count on administration. Other studies using narrower definitions land closer to 25%. But even at that low end of the estimates, the picture is the same. And here's the part of the conversation that should bother us. Every one of those dollars is being spent on the argument itself, on billing, on reviewing, on approving, on appealing, and on negotiating. One army exists to submit the claim, another army exists to question it, and a third exists to appeal the answer. None of that produces a single additional day of health for anyone. So when people say the system feels adversarial, they are not imagining it. For decades, the financial relationship at its core was built as a negotiation. And we have built an enormous industry around conducting that negotiation. There's a human cost underneath the financial one, which I think matter more than anything else. Research by David Cutler and Dan Lee showed that compared to Canada, the American health system carries about 44% more administrative staff. And American physicians spend a higher share of their working hours on administrative tasks. than their Canadian counterparts, do roughly 13% of working hours against about 8%. Think about that. Think about what that means in practice. We took people who trained for a decade to care for patients, and we gave a meaningful part of their week to paperwork that exists because two organizations do not trust each other. And then we are surprised when they burn out. This is why I argue that administrative burden is not a back office problem. It is a workforce problem, and it is a quality problem. Every hour a physician spends justifying a decision to a payer is an hour not spent with a patient. Now there's a question. How is that relationship changing? I can explain that something very interesting has started happening. The wall between payer and provider is beginning to come down. And it is happening in two ways. The first is the shared risk. Under value-based arrangements, providers take on some of the financial responsibility that used to belong only to payers. When a provider is accountable for the total cost of population, they begin to think like a payer about prevention, about efficiency, and about appropriate use. Suddenly, the two sides want some of the same thing. And notice what that does to the friction. If the provider is already accountable for the cost, then the payer has far less reason to sit in the middle and question every decision. The prior authorization exists because the payer does not trust the incentive. Change the incentive and you reduce the need for the argument. That is the most hopeful development in this entire relationship. Now we talk about the second, which is integration. Increasingly, payers are buying providers and the providers are launching their own insurance plans. The boundary that defined the conflict is being erased from both directions. But this has raised serious concerns too. Concentrated power raises real questions about competition and about patient choice. And I do not want to wave those away. When the organization that decides what care you need is the same organization that pays for it, the check that used to exist between them disappears. That check was frustrating, but it was doing something at least. But still, it does change the dynamics. When the same organization delivers and pays for the care, the old adversarial logic no longer fully applies. So the future may look less like a negotiation across a table and more like a single system trying to balance cost and care from the inside. Whether that is better for the patient is honestly still an open question. And then there's a third change, which is quieter, but I think it will matter more than the people expect. Both sides are now applying technology to the friction itself. Payers are automating review, providers are automating submission and appeal. And I want to be honest about my own view here, because I do not think this is a straightforwardly a good news. Automating the argument makes the argument cheaper. It doesn't make the argument unnecessary. If both sides simply get faster at fighting each other, we have not fixed anything. We have only just industrialized the argument. Now, the real question is not a better prior authorization process. It's a payment model where the prior authorization was never needed in the first place. So, the next time you experience friction in healthcare, a delay, a denial, and a bill you did not expect, understand what is actually behind it. It is rarely one bad actor. It is a structural tension between two groups with different jobs and historically with opposite incentives. The payers stewarding cost across a population, the provider delivering care to an individual. For a long time, those two roles pulled against each other, and the patient absorbed the friction in between, while all of us paid for the machinery of the argument. What is changing now is that the system is slowly trying to align them through shared risk and through integration. But it's not finished. It may never be perfectly resolved, but the direction is clear. The future of healthcare depends on turning that old tension into something closer to a partnership. This has been HealtheNomics. I'm Dr. Ayoub Ashraf. If this was useful, follow the channel and I will see you in the next episode. Thank you so much.